morning. My name is Geoffrey Pelz. I'm a thoracic surgeon at Hackensack University Medical Center. We're going to be talking about lung cancer screening. And some of the topics we're going to be going over, why are lung cancer screenings important? What are some common risk factors for developing lung cancer? What are some working environments and occupations that could result in a higher risk of developing lung cancer? What exactly is lung cancer screening? Who's eligible for screening? And then what are some methods that are used to biopsy and diagnose lung cancer and ultimately undergo treatment? So the obligatory statistics, why is lung cancer screening important? It's the third most common cancer in the United States, following breast and prostate cancer. Despite being the third most common, it's actually the leading cause of cancer deaths in the United States, accounting for about 20% of all cancer-related deaths in the U.S. So you can kind of see the graphs of some different incidences of various types of cancer. This tall line here is for lung and bronchus cancer. This is for men on this side, women on the right. But basically, since the advent of smoking picked up speed in the 40s and 50s, you can see the incidence of lung cancer rising dramatically and peaking at about in the 1990s for men and about in the 2000s for women. And the incidence is dropping now due to the decrease in smoking among men and women. And women didn't peak quite as high over here, and took a little bit longer, closer to the 2000s, for women to kind of stop their smoking and incidence decreasing. But as the smoking-related cancer incidence decreases, there's a higher proportion of people with lung cancer that are non-smokers. So we'll talk about that as well. There's a lot of misconceptions about lung cancer and who gets lung cancer. So, hear very commonly from patients that they feel fine, they don't have any symptoms, so there's no way they can have lung cancer. And the fact is that really most people that have lung cancer will have no symptoms at all until they get to much more advanced stages, to where treatment is, less likely to cure the cancer. And so really screening is the only way to pick these cancers up early and to be able to have the best chance to treat it and cure it. And a lot of people think that lung cancer is just in smokers, and about 20% of lung cancer cases can occur in people that have been never smokers. And so just because you're not a smoker doesn't mean there's not some risk for developing lung cancer. And there's kind of a stigma around smoking and lung cancer, both from non-smokers and seeing people that get lung cancer and think that basically it's their own fault because they did it to themselves, and also some guilt among people that actually develop lung cancer that are smokers, and again thinking that basically they did it to themselves. And so sometimes there's a reluctance to seek out getting screened and to get treatment, but hopefully we'll dispel some of that today. A lot of people think because they go to their primary care doctor every year, they get their routine blood work, maybe even get a chest x-ray, that there's no way that they'd have lung cancer because it'd be picked up on that stuff. And really most routine blood work does not screen for any cancers, including lung, and that chest x-rays, as we'll see, can miss a lot of smaller lung cancers and are not a very good way to screen for lung cancer. And then in terms of treatment, a lot of people think that, as we said, that lung cancer is the most common cause of cancer-related death in the U.S. So, why bother even get screened? There's no way to treat it. And the fact is that as we screen people, detect lung cancers earlier, and have newer treatment options available, that we can cure lung cancer, and the survival rates are improving with time. And people think that the treatment is worse than having the disease. And, things are very different now. Not everybody gets a big cut on their side and crack their ribs and all that kind of stuff that people may have a family member or a friend or somebody that had surgery, chest surgery in the past, and things are different with minimally invasive treatments. There's other radiation treatments and other things that can be done to treat lung cancer as well. So as we mentioned, there's really most people don't have any signs or symptoms of lung cancer until it reaches a more advanced stage. Sometimes you can have a cough, you can cough up blood, have some vague chest pain, shortness of breath. unintentional weight loss and hoarseness, but these are all kind of non-specific symptoms, and they can be seen in a lot of different types of diseases. So nothing there is really specific for lung cancer. And again, the only way to detect it early is with a CT scan of the chest. So going over the risk factors for lung cancer, obviously the most common thing is smoking in about 85% of cases. And you can have up to a 30 times increased risk if you're a smoker compared to non-smokers, and that does include cigars and pipe smoking as well. It's a little bit tougher to quantify that, so typically we just talk about cigarette smoking, but other methods are putting at increased risk for developing lung cancer as well. Second most common cause of lung cancer that most people don't really know about is exposure to radon gas. And so in this little cartoon over here, basically radon is a colorless, odorless gas that's radioactive gas in rocks deep in the soil. And if those rocks can kind of crack and leach that material out into the soil, it can get into your house. If you have well water, it can kind of come in through there. Or if you have cracks in your foundation, sometimes it can get in, especially in basements with poor ventilation. Concentrations of that gas can accumulate there and put you at risk. The more you're exposed over a longer period of time will increase your risk for developing lung cancer. And so usually when people buy a new house, they'll do radon testing. But if somebody's been living somewhere for a very long time, or maybe they've never had testing done, it's important to check to make sure that you're not getting exposed to radon. You can get test kits at local hardware stores, and in certain local government areas, there may be programs where you can actually get those testing kits for free. And if you do find out that you have increased levels of radon, you don't have to necessarily leave your house. There are mitigation efforts that can be done to increase ventilation and other things that you can have professionals install that can help to decrease that concentration of radon and make your home safer again. Another thing that people can be exposed to that will increase the risk of lung cancer is asbestos. Usually most people think of asbestos exposure in relation to a different cancer called mesothelioma. You'll see those commercials on TV all the time for asbestos exposure and mesothelioma. But in addition to that cancer, which is actually a kind of a separate cancer of the inside lining of the chest, and that takes about 20 to 30 years to develop after significant exposure to asbestos. And so obviously both exposure to asbestos and mesothelioma rates have been decreasing significantly since that was outlawed. But there's certainly still some occupations and risk of being exposed to asbestos, and then you can have increasing risk of lung cancer. And probably one of the highest risk groups are people that are active smokers and have been exposed to asbestos. You can have about 100 times increased risk of developing lung cancer. So those people are very high risk and should definitely get screened. Secondhand smoke is something else that is a risk factor for lung cancer as well. Certainly less now when you can't smoke in every restaurant and on the airplanes and things like that. But there's certain occupations, and certainly if you're in a household with smokers, you can get exposure to secondhand smoke and increase your risk for lung cancer there. And then a lot of environmental and occupational exposures with being exposed to various metals, silica, nickel, and organic chemicals such as benzenes and other volatile organic compounds, radioactive ores such as uranium, and then diesel exhaust can all put you at increased risk for developing lung cancer. So certain occupations are going to be exposed to those things more commonly. So obviously construction workers, people that are building ships may be exposed to a lot of those dusts and metals, and specifically asbestos, lining the pipes on ships and things like that. So those people will be at increased risk for lung cancer. Miners, other industrial workers, painters, and rubber and plastic workers will get exposed to a lot of those organic chemicals and benzenes and things. People that are transportation workers, especially if you're in kind of poorly ventilated areas, you may get exposed to a lot of diesel exhaust. And people that work in the hospitality industry, casino workers, where there is still significant exposure to secondhand smoke, may have increased risk there. And obviously the problem with these jobs is that you're chronically exposed to these chemicals and things over a long period of time, over years to decades. And so that exposure builds up over time. And it can be worsened if you lack proper protective gear for doing your job, or if you don't use that gear correctly, working in areas with inadequate ventilation, that can certainly put you at increased risk for developing lung cancer. So as we mentioned, there are a significant portion of people that are non-smokers that can get lung cancer. It's upwards about 20% in the United States. It can be 25% globally, and it's becoming a higher proportion of the overall lung cancer cases as smoking rates decrease. There are other specific high-risk groups as well. Obviously, we talked about the occupational exposures, but certain groups, especially women and Asian women, non-smokers, can have much higher risks of lung cancer than kind of the average U.S. female. About 57% of Asian American females that are non-smokers that get lung cancer, of all females in the U.S. That are never smokers can have lung cancer, and it's 80% of Chinese females are non-smokers that get lung cancer. So East Asian descent, people with family history of lung cancer, there's some other potential risk factors, and we'll see when we talk about screening criteria that these people in groups don't exactly fit into the specific criteria, and so sometimes it's a little tougher to know who needs to be screened. Part of what drives lung cancer in non-smokers is the actual genetic mutations in the tumor cell DNA, and that's something that's important when we do biopsies or resect somebody's lung cancer. That tissue is sent for this additional genetic testing, and we may see certain mutations in that tumor cells, and that'll help to dictate what additional treatment may be able to be used. So there's a lot of newer medications other than just chemotherapy. We have to know exactly what mutation is in the tumor cell DNA, and that'll dictate what the treatment's going to be. And so what is a screening test? We know some of these tests already. Mammograms are used in breast cancer, colonoscopies, and other tests can be used to screen for colorectal cancer, pap smears for cervical cancer. Basically, you want to have a screening test that can detect cancers early before somebody is symptomatic, and when the treatment is more effective and have a higher chance for curing cancer. And for lung cancer, that's going to be a low-dose CT scan of the chest. And so a low-dose CAT scan, basically, this is a kind of an image of a CAT scan machine here. And it's a special type of scan that they do where they'll use 4 to 5 times lower dose radiation than a regular diagnostic CT scan. But it'll take hundreds of detailed images of the lung and can detect nodules or masses or other abnormalities in the lung. These scans only take about 10 minutes for the total time to be performed. It's quick and painless and non-invasive. And as you can kind of see here, it's just more of an open donut as opposed to an MRI, which that's where very claustrophobic and enclosed and hot and sweaty and have that banging magnet. And so these are much quicker scans. Takes about 30 seconds for the actual scan in an open environment. And so it's much better tolerated for people that are claustrophobic, and really should be no excuse to not get your lung cancer screening scan. And so lung cancer screening is a fairly recent thing. There was a landmark trial that came out in 2011 in the New England Journal of Medicine, where they took a look at 53,000 people and compared low-dose CT scans of the chest to chest x-rays. And in the CT scan group, actually saw a 20% decrease in your risk of dying from lung cancer as compared to that x-ray group. And so this was first time that we really proved that CT scans are the superior way to screen for lung cancer. That being said, it's taken quite some time for this to really be adopted in practice. About 2 years later, the U.S. Preventative Services Task Force came up with their initial criteria as to who should actually be screened. And they recommended a yearly low-dose CT scan of the chest in patients that are aged 55 to 80 that have a 30-pack-year smoking history. And basically what that means is if you smoke a pack a day for a year, that's 1 pack year of smoking history. And so you can kind of do the math. Say a person smoked half a pack per day for 40 years, that comes out to a 20 pack year smoking history. And so they recommended, again, age criteria, the 30 pack year smoking, and in active smokers or people that had quit within the past 15 years, because your risk does decrease over time after you've quit smoking, but never goes quite to zero at baseline. So we'll show you some numbers on that later. But basically, they recommended screening until you hit age 80 or quit over 15 years prior, or otherwise develop health problems that would prevent you from getting treatment. And the following year, private insurers started to cover the scans. And then the next year in 2015, the government and Medicare and Medicaid began covering these annual low-dose CT scans of the chest. The criteria was revised in 2021 to where they decreased the initial age for screening from 55 down to 50 and decreased the amount of smoking from 30 pack years down to 20. And they still recommended only inactive smokers or people that had quit in the past 15 years. Same with the screening until age 80. But basically, by decreasing the age and the smoking, they doubled the number of eligible people that would be able to get these lung cancer screening scans. In 2023, the American Cancer Society actually removed that quit within the past 15 years criteria, because as your risk decreases after you quit smoking, it does not go to a baseline for a non-smoker, and so there's still some increased risk there. And there are some potential downsides to screening, both from a public health perspective as well as from individual patient perspective. So we talk about kind of a number needed to screen, and so you'd have to screen 100 patients with these low-dose CAT scans to find one lung cancer case, and this is in high-risk groups. So you can imagine, as we broaden the criteria, you're having to scan many more people to pick up that one lung cancer case, and there's some cost to the public health system for that. So not everybody gets a yearly CT scan, because there are some other potential downsides to screening. Certainly radiation dosing is something that I've heard mentioned, but it's a very low dose for these scans, and lower than a general CT scan of the chest, and really hasn't been proven to have any sort of risk long term for getting CAT scans. So really the radiation dosing should not be a concern. What is more of a concern, and is potentially a real thing, is picking up incidental findings or false positives on scans that can lead to additional unnecessary tests, including biopsies or other procedures. And so that's the rationale for screening only in high-risk patients, where the chance of what you find on a CAT scan is much more likely to be a lung cancer than a low-risk group. And so for these lung cancer screening scans and programs, there's very strict criteria, and it's what's called a shared decision-making model that happens between the physician and the patient. And so in a visit with a physician, they have to confirm the eligibility criteria of the patient, discuss these potential benefits and harms of the scans, talk about the need for any follow-up tests and procedures that may need to be done if something's found on the scans. And it's important to know that you're going to need to get a yearly scan to provide the maximal benefit from these. Just because something doesn't show up one year does not mean that the following year something can't show up on the scan. And as we talked about, smoking cessation is very important for your lung cancer risk as well as for other health benefits. And you have to make sure somebody's able to undergo treatment if you can diagnose a lung cancer. And again, there's treatments other than just invasive surgery, so that shouldn't always be a deterrent. And then need to have a use of some sort of a decision aid to help patient understanding. And at the end of all of that, you get your prescription for your low-dose CT scan of the chest. And so just to kind of recap who and when to get screened, the age criteria currently is age 50 to 80 with a 20-pack year smoking history. Again, the American Cancer Society recommending not to have that 15-year cutoff. And certainly if somebody's had a prior lung cancer, they're at risk for developing a second one. So I'll essentially screen patients forever after they've had a lung cancer. And, there's people over 80 that are in excellent shape that probably should still continue to get screened. The problem comes in these kind of formal lung cancer screening settings of what to do with high-risk occupations and other ethnic groups, because they don't fit into this exact criteria. So there may be issues with either insurance or Medicare or Medicaid covering these screening scans. So there certainly are other people that don't fit this exact criteria that should get screened. If you're in one of the high-risk occupations or one of those ethnic groups, still may be beneficial to get a CT scan of your chest. But these are things that you're going to have to discuss with your personal physician. And, there may be other ways to order these scans and not through a strict screening criteria. As we get more information and find out more, we may add certain subsets into this screening criteria. There's a study kind of ongoing in San Francisco looking at Asian females and other high-risk groups. And so, at some point we may have kind of breakout criteria covering other people. But for now, this is kind of the official criteria of who should get screened. So after you get your screening scan, what happens is CT is read by a radiologist, and you'll get this report in this what's called a lung rads kind of format here. And there's various categories. If it's a very low risk, either there's nothing on there or something that's clearly not a lung cancer, you'll get your repeat CAT scan in a year. If it's something that's a very low risk of cancer, then you may recommend repeating a CT scan in 6 months instead of a year. And then once you get into the lung rads 4 categories, then there's a much higher risk of what you're finding on the scan to be a lung cancer. And so either getting a very short interval 3-month follow-up scan, or getting a PET CT scan, or if it's something that's a very high chance of being cancer, getting a PET scan and or a biopsy and referral to a specialist for further evaluation. So typically, if somebody either has a biopsy-proven lung cancer or something is suspicious for lung cancer, the next step would be to get a PET CT scan, and it stands for positron emission tomography. And basically, this is a nuclear medicine scan where they'll inject some radioactive sugar into your IV, and you have to kind of wait there for about 60 minutes for the sugar to get taken up by the cells. And then they'll do the scan, and areas where there's kind of activity will show up on that scan. And so I always caution patients that just because something shows up on the scan does not necessarily mean that it is a cancer. You can have inflammation, infection, other things that can show up on the scans, but certainly that will highlight areas of concern. And just because something doesn't show up on the scan doesn't mean that it's not a cancer as well. And so you can have small nodules, things that are not solid or that are growing very slowly that could still be cancers even if they don't show up on this PET scan. But basically, the scan will kind of scan you from your chin down to your knees. It's not good for looking into the brain because the brain is active, so that whole thing lights up. So there are certain instances where we'd have to get different imaging for the brain. But basically, you can see, excuse me, on these images here, this is kind of the regular CAT scan image with kind of a lung mass here, and then there's a big lymph node mass in the center. Over here, you can see on the PET part of the scan, the lung mass shining very brightly, and here's this lymph node mass lighting up as well. So that's important, especially as a surgeon, to kind of see, is something just confined to the lung? Are there areas outside the lung that look concerning that may have spread outside the lung? And are those areas we need to target for biopsy? So what methods can we use to biopsy and potentially diagnose a lung cancer? There's basically 3 big categories. One is to do a CT-guided needle biopsy. And those are performed by interventional radiologists under local anesthesia. Basically, they'll numb you up from the outside and stick a needle in directly into the lung and get tissue that way. There are some risks with doing these. You're basically putting a needle into a balloon, and so there's a risk of air escaping out. And sometimes you can get what's called a sampling error. So if you have a mass of a certain size and you're sticking a needle into only one part of it, it's not always diagnostic of what's going on in the entire mass. So if you get a biopsy that doesn't show cancer, it's still something you need to keep track of and do follow-up scans to make sure it doesn't continue to grow and that you didn't get a false negative result. But that's one option. Another common option is to do a bronchoscopy, and there's different types of those scopes. There's kind of a standard scope with a bigger camera on it that you can look at the central airways in the middle. There's an ultrasound scope that we can take a look on the outside of the airways for either biopsying lung nodules or more commonly to biopsy lymph nodes. And we have a special kind of a GPS bronchoscopy called the navigational bronchoscopy that I'll go into in a little more detail here as well. And sometimes we'll skip the needle biopsies in somebody where we've tested out their heart and lungs and they're otherwise in good shape and they're a good candidate for surgery and something's very suspicious. Sometimes we'll go straight for surgery and just taking it out. So going back to the bronchoscopy, these can be performed by pulmonologists or thoracic surgeons. And this is kind of a picture of the scope with this kind of thin, flexible camera here. And that can go down through the mouth and into the airways. Sometimes these are done under kind of a twilight or sedation anesthesia, or can be done under general anesthesia. And we can then put needles and brushes and biopsy tools through the working channel of the scope and collect tissue that way. On this lower image here, you can actually see the ultrasound scope, and this is a lymph node here. We're sticking a needle directly through the airway into the lymph node. And this can give us important information about staging purposes and if the lung cancer has gotten outside of the lung and into the lymph nodes, and that may affect what we do treatment-wise. And then kind of the third option is what we use at Hackensack as an ion robotic bronchoscopy machine. And these can be performed by either the pulmonologist or thoracic surgeons. This one does require general anesthesia. But basically, we can drive a tiny camera to any part in the lung to be able to reach it to then do biopsies from the inside of the airways. And so this is kind of the general setup. Sometimes we do require getting a new CAT scan because it has to be done in a certain format with additional information. But basically, I can take that disc and plug it into a computer and have the software create a 3D reconstruction of the lung and the airways. And then basically, like GPS for your car, I can give it a target that I want to go to, and the software will give me a little pathway to follow through the airways when we're in the operating room, and can be able to reach different parts of the lung. So basically, this is the actual machine off to the left here. And in the center, we have a patient with a breathing tube in, and there's a little tiny camera that is able to go down through and into the airways there. And then basically the person doing the procedure stands here at the console to be able to control everything. And then when we're doing biopsies, we have basically this, it's almost like a mini CAT scan machine here, where it'll take multiple images and kind of recompile them. So once we stick the needle out, we can confirm that we're actually in the target, because there's something called CT body divergence, where basically sometimes the live picture doesn't line up with the CAT scan. And so if you're off by a couple millimeters, you may miss the target. And so it's important to be able to know that you're actually getting a good sample when you're doing these tests. So this is what the console looks like. There's a little scroll wheel to be able to advance or retract the catheter, and then a little trackball here to help guide it. I always liken it back to people that are old enough to remember Centipede in the arcade in the 80s here with this little trackball controller. So I talked to patients about that. But basically, this is what we'll see in the operating room. Over here is to the left is the CAT scan, kind of the virtual view, and here's a live view inside the airways. And we start by going down into the different parts of the lung, and you get the little check marks to where it registers the CAT scan data to the live picture. And then I can follow this blue line and drive that little tiny camera out to different spots in the lung and be able to do biopsies. And then in this bottom right picture, this kind of greenish dot here is the actual nodule that we're going to biopsy. Here you can see the little tiny catheter all the way inside the lung, and this kind of darker spot here is the actual mass. And this can tell me kind of how far away I am from the target, how far I have to stick my needle out. It can tell me where the edge of the lung is. So there's a lot of cool technology here that we can utilize when doing these biopsies. And then basically here I can stick the needle out into the lung. And then here we've done that kind of 3D CAT scan, and I can review the images. And it's a little bit tough to see, but there's just kind of a little hazy spot here, and this is the needle going into that. And I can scroll those images back and forth and confirm that I'm actually in the target to do the biopsy. And then there are times when we know that somebody's not a surgical candidate, and so we can put little markers here. You see something called a fiducial, and we can put those in the lung at the same time as doing the biopsy. And then the patient can undergo a special type of radiation where they only have to get a few treatments, and that can cure off or kill off the cancer cells and cure it in people that are otherwise not candidates for surgery. So third option is surgery, and sometimes, again, we'll skip straight to surgery, but basically it's my job to test somebody's heart and lung function and see if they're a good candidate for surgery. And so we need to know how much lung we're potentially going to be taking out of somebody and what their baseline lung function is. And that way I know that after surgery, they're going to be fine, have the same quality of life as before surgery, same lung capacity, same exercise tolerance. Because obviously, if we're going to compromise somebody's lung function and quality of life and have them end up on oxygen permanently or something like that, then we're going to offer other alternatives to surgery and do different treatments. And so, we'll need to know that information before going for surgery. But obviously, surgery requires general anesthesia, but there are definitely minimally invasive approaches to this, and we do a lot of robotic lung surgery. You can see the robot with the arms and instruments here. And as the surgeon, you kind of sit here at the console and you work the little controls here, and that moves the instruments inside the patient. So minimally invasive surgery has dramatically improved the treatment of surgical patients. People can undergo surgery. Sometimes we'll send them home the same day as the procedure. And even if we're doing a larger operation, a lot of times they can go home the day after surgery. And so, dramatically improves recovery. Not everybody gets a huge cut on their side where you crack the ribs. And again, there's a, kind of a perception out there in some people that surgery is really traumatic, and that's not always the case. And so, people can get back to, get off pain medicine in a week's time and get back to most normal activities in about 2 weeks. And so, it's a very good option for most people. But if somebody, has poor lung function, has a lot of other medical issues, and are not a good candidate for surgery, there's other potential treatment options. And again, for kind of a local treatment for something that's an early stage lung cancer that's just confined to the lung. If surgery is not an option, then radiation can sometimes be done. And this is a special type of radiation called SBRT, or stereotactic body radiation therapy. Some people heard a gamma knife in the brain or a cyber knife. And rather than kind of a lower dose treatment where you got to go for 40 sessions, like say for breast cancer or other treatments like that, this is only about 3 to 5 very high dose radiation treatments that can kill off any cancer cells. There's some criteria. Usually it has to be smaller spots that are less than 5 centimeters, have to be away from certain structures and things in the body. But basically, this is a very good treatment option for people that are, maybe have a lot of medical problems, that are sicker, that have poor lung function, on home oxygen, and there's still treatment that can be done. Sometimes we'll need whole body medications, either before surgery, in lieu of surgery, or after surgery. Obviously, the thing people most think about is chemotherapy. And that's kind of a non-specific shotgun approach that kills off any fast-growing cells. And that's, has a little more risk of side effects and losing your hair and things like that. There's a lot of newer treatments and targeted immunotherapies that can be done. But again, it's important to know what the mutation profile of the tumor cell DNA is. And so, again, in non-smokers and certainly in smokers as well, we may test for some of these mutations. And they may be able to block a specific enzyme reaction in the body, and can have better response rates with fewer side effects. And some are infusions, some are actually pills. And so these can be good treatment options for people that may not be able to tolerate chemo, or can be used in combination with chemotherapy. I mentioned immunotherapy. People may see commercials on TV for Keytruda or Opdivo. Some of these can be treated or be used in other cancer treatments as well, not just in lung cancer. There's kind of newer treatments on the horizon. One is potential for personalized vaccines, where basically you would do a biopsy or potentially resect a lung cancer, and then they can actually develop a vaccine from that specific tumor, and then give that vaccine back to the patient, and can help ramp up the immune system to try and go and treat that cancer. There's always new investigative drugs and ongoing clinical trials and things. And so, in the future, we may be able to get away from lung cancer screening scans to where there may be a blood test that you can do that can screen and then get the CAT scan after that. And ultimately, there may be more non-operative treatments as well. But for now, lung cancer screening scans are really going to be the best way to kind of decrease your risk from lung cancer, be able to identify that early, and have all the treatment options available to you. Obviously, we talked about smoking cessation and how important that is to decrease your risk of lung cancer, and multiple other health benefits as well. Testing your home for radon and undergoing those mitigation efforts if need be, avoiding other environmental toxic exposures. If you're in a high-risk occupation, making sure you use your safety equipment properly, and trying to minimize your risk if you are exposed to some of those diesel fuels or chemicals or other things that we talked about. In general, lung cancer screening has been very slowly adopted. That study came out in 2011, and for many years, we were only screening about 6% of the overall eligible population. So for instance, mammograms, it's about an 85% adherence rate to screening the people that are eligible for colonoscopy and colon cancer screening. That number is at about 80%. So we got a long ways to go with lung cancer screening to where we hit those numbers. Things are improving as education both of general patient population as well as physicians is improving. And we're up to maybe 20% of eligible people getting screened, but it's, again, nowhere near for breast cancer, colon cancer, where, again, lung cancer has the highest rate of death from cancer in the United States. And so want to make sure that people are getting screened. So just kind of briefly to go in, what happens if you do quit smoking? So we talked about active smokers have about a 30-time increased risk of developing lung cancer versus non-smokers. But once you do quit smoking, your lung cancer risk does decrease over time. By about 10 years after quitting smoking, you're at about 50% the risk of an active smoker. And by 20 years, that risk kind of plateaus down to about 2 to 3 times the risk of a non-smoker. But that never goes all the way back down to baseline, which is why I do advocate for maybe screening beyond that 15 years of having quit smoking. There's many other health benefits to quitting smoking. The kind of chronic smoker's cough and some shortness of breath will decrease after about a month up to a year time. Your risk of heart attack drops by 50% in about 1 to 2 years after quitting smoking. The risk of stroke drops in half by about 2 to 5 years. Multiple other cancer risks will drop as well. So quitting smoking is very important. Obviously, it's very difficult to do. Otherwise, everybody would quit. But there's smoking cessation programs, and I'll show the brochure here in a second, and other potential help out there to be able to quit smoking. Vaping and e-cigarettes was a topic that had kind of come up as well. And so a lot of people think maybe they'd just be able to vape or use e-cigarettes, either in combination with smoking or instead of smoking. But as we're getting more and more data from the people that are using e-cigarettes, we're finding out that the risk is still there. You're still exposed to a lot of toxins and carcinogens. So those things are not really that safe. And we've actually found out that there can be a 4 times increase in people that are active smokers and vape as well of developing lung cancer. So there's, again, a synergistic effect of those exposures of both cigarette smoking and vaping. And so really it's not a safe alternative to smoking. Something that was a hot topic kind of back in 2020 before COVID hit, especially in younger people, was kind of this vaping-associated lung injury, mainly from vaping of CBD oil and some of the glycols and stuff in those types of formulations, and that getting into the lungs. And you'd see people in their 20s and 30s that were potentially dying from lung failure from vaping. So it's gotten better with time, but still, it's certainly something that need to be aware of. And so smoking cessation programs are available to help quit smoking. We have one through Hackensack Hospital and the John Thurr Cancer Center. And so there's a number to call, text, or to email. And certainly in other areas of the state and other parts of the Meridian Health System, there'll be local smoking cessation programs to take advantage of as well. And obviously, lung cancer screening programs are important. Your primary care doctor or pulmonologist can do these screening scans for you. But if they don't know about it or don't want to take that on, or you don't have a physician, you can call our lung cancer screening program at Hackensack. And again, there'll be places other than just in Hackensack that you can look at the website to take advantage of, but can get into a formal program where we'll be able to do the scans for you and provide the follow-up and everything. So that's all I have for my talk, and we can take a look at questions here.
Thank you so much. Actually, some people had emailed me before the webinar, so I'm just going to start with those, and then as people send them through our Q&A, feel free to answer. We can answer them then. I just want to get them out of the way so that we can address those that were here. But I did have a question myself. You mentioned that there were blood tests for lung cancer. Is that to determine your risk for cancer or your current status of like whether or not you have lung cancer or not?
So they're becoming more prevalent. They're not kind of finalized yet to where it can replace screening scans, but they're basically looking for active tumor cell DNA in the blood, so they can kind of amplify very low parts of tumor cell DNA that may be circulating in your active bloodstream. So it's not so much the risk of lung cancer; it's more to determine if you actually have active lung cancer. And again, they're not perfect tests by any means yet. They don't screen for all cancers. And so at this point, doing the low dose CT scan of the chest is really the way to go to help screen. But, it's coming down the road. So probably within 5 years, maybe we may be doing more routine blood tests. And certainly there's going to be easier to reach a larger patient population, where maybe not everybody will be able to get the CAT scan, but can get the blood tests, and that would be kind of the initial trigger to then get a CAT scan. So more to come on that later, but it's looking for active tumor.
That is awesome. That just put a smile on my face. That'll seriously change.
That reminds me, sorry to interrupt, but we're working actually involved in a study with our surgery group about looking at exhaled breath as well. So being able to actually collect somebody's breath as they breathe out and screening that for lung cancer cells as well. So it's another method in addition to blood.
That is awesome. We'll definitely have to do some Health U content around that. And then, like I said, I had a couple of questions from email. I know that you touched vaping. The question was, is it safer to vape? And so you answered that, but also about hookah. What about hookah?
People ask all the time about either hookah or certainly, vaping, or not vaping per se, but smoking marijuana, other things like that. Anything that you're going to be inhaling into your lungs is going to have some toxins to some extent. I think some of those things are probably going to be safer than cigarette smoking and vaping, but you're still going to probably have some risk of either lung cancer or other things. But certainly, there's a lot more information on vaping that's definitely not a safe alternative.
All right. Great points. How do I know if a cough is just a cough or when I should talk to my doctor about getting a screening?
So unfortunately, as we talked about, there are really no specific symptoms for lung cancer. And so that cough could be, just a bronchitis. It could be infection, upper respiratory tract infection, could be related to heart disease, could be related to the lungs. And so certainly if you have something that persists for ongoing time, then, definitely would recommend talking to your physician. Obviously, people that are chronic smokers will get a kind of chronic non-productive cough. But, obviously, and those people are potentially going to be eligible for lung cancer screening anyway, and are the people that we're looking at capturing and getting those low-dose CT scans. So, certainly if you have an ongoing cough, and really if you're coughing up blood, that's definitely a major concern. And so you should talk to your doctor about that.
All right. And then the last question that I got before our webinar, somebody had mentioned that their husband was recently diagnosed with lung fibrosis. What causes it? What are signs? And what are some treatment options?
So fibrosis is kind of a different entity. And you can kind of think of as more scarring inside the lungs. There's some different causes for that. Sometimes it can be environmental exposures. Sometimes people with severe gastroesophageal reflux disease can have kind of an ongoing chemical burn in their lungs that can cause damage to them. Again, a lot of those kind of environmental and occupational hazards with inhaling dust and other toxins can cause that. But basically, it causes scarring inside the lungs and will decrease your lung function and capacity over time. There are some treatment options. Some of this is kind of irreversible once it is identified, but there are specialized pulmonologists that can sometimes use newer medications and infusions that can help treat fibrosis. Ultimately, if it comes to kind of an end stage point, that people may need to get actual lung transplant if they have end stage fibrosis, if they're a candidate. So it's again kind of a different entity, but speaking with a specialized pulmonologist as a medical lung doctor can help kind of guide that. But that may be something that can be seen on low dose screening CAT scan as well, and pick that up.
Okay, and now I'll go to the questions that were asked in here. I live in a townhouse and my neighbor smokes in their backyard and I sometimes smell it. Does that put my family at risk?
So a lot of these exposures are kind of dose dependent and time dependent. So, if you're getting a little bit of secondhand smoke in kind of a ventilated environment outside, getting a kind of minor exposure, your risk is probably not going to go up at all for getting lung cancer. If you're living in a household with an active smoker who's smoking inside and you're kind of constantly exposed to that, if you're riding in a car with somebody on a daily basis, I think that's going to put you at a much higher risk. So, you can never say with 100% certainty that any sort of exposure you may be getting from a neighbor is not affecting you, but it's probably not going to be the same as obviously smoking yourself, having radon exposure, or being in an enclosed environment on a kind of a daily basis as your job or something like that. So I would think the risk is fairly minimal there.
Okay. This is a great question. Is it a good idea for non-smokers to get screened?
So that's a difficult one. We did talk about certain high-risk non-smoking groups, either from an occupational perspective, from especially Asian females, people with a family history, and so there definitely may be people that will benefit from getting these types of screening CT scans. The problem is we don't really have strict criteria to include those people, and so if you were to try and order a lung cancer screening scan on somebody that doesn't fit the age and smoking criteria, that's not going to get covered by insurance. So really in those instances, if you think you're at potentially high risk for lung cancer, that's a discussion you're going to have with your physician, because there are ways to order scans that may not be just a low dose screening CAT scan, but they may be able to get a CAT scan for another reason and accomplish the same task of picking up an early lung cancer. So certainly, if you are a Asian female non-smoker with a family history of lung cancer, then I think that you would definitely benefit from getting a CT scan of the chest. It just may not be able to be done in kind of a formal lung cancer screening program.
That brings up a really good point. If we think about it, 50 years ago, not even 50 years ago, everyone smoked everywhere you went, and even if you weren't smoking, you might be potentially at risk. So that's a really great question. I appreciate you asking that question. The last question I have here is, a sister was diagnosed with pneumonia multiple times in a year and was diagnosed with lung cancer. Diagnosis to death was less than a month. Was the cancer likely missed? Ooh.
So obviously that's a very difficult situation, and I'm sorry that happened. I obviously don't know what sort of scans may or may not have been done. Certainly people can have cough and fever and get either an X-ray or ideally a CAT scan, and you may have something it's called consolidation, where it's more of just kind of a overall dense area of the lung. And so, most of the time, if somebody's, coughing up green stuff and has a fever and, likely have pneumonia, you see a doctor, you get treated with antibiotics, maybe some steroids. And especially, if you get imaging, you want to get follow-up imaging to make sure that clears. And so, if you go through the treatment, or maybe say you really didn't have symptoms in the first place, or very minor symptoms, but they saw something on a scan, you want to see that scan improves. And so there are times that lung cancers can kind of hide within a pneumonia, or certain subtypes of lung cancers that actually just look like pneumonia as a baseline on those scans. And so somebody that has an infection, that should get better with time. And so a lot of times we would do a follow-up CAT scan at maybe a month, make sure something's getting better, or being checked after maybe 3 months. And so getting that follow-up imaging to make sure that things are improving. And if they don't, then that may warrant getting a biopsy. So obviously I can't give formal legal advice in this sort of setting, but there are times that lung cancers can kind of masquerade as pneumonias. And so it's important to talk with your doctor. And if you get a scan, if there's something there, to get that follow-up imaging, because sometimes those do turn out to be lung cancers.
Thank you. That's scary. Someone once told me that nicotine was being used in cancer treatment. Is this true? I thought it was just for treatment of chemo-induced peripheral neuropathy as a side effect of chemo drugs. Is it nicotine bad for cancer?
Yeah. So there's no formal sort of treatment of lung cancer with nicotine. That may be kind of one of those things out there in the ether. There's all sorts of some alternative treatments and things like that. Some of those are not really medically recommended. Certainly, just in general, having a good healthy lifestyle with a good diet. If you're undergoing cancer treatments, that's important to your overall health and treatment response and ability to get through cancer treatments. And having the proper mindset and kind of the mind-body connection, being able to fight getting through cancer treatment is important. But there's no kind of formal nicotine treatment that I'm aware of, at least.